So we've talked a lot about the difference between an intracerebral stroke and a subarachnoid stroke. And we know that because of the differences in pathologies that each is going to have its own clinical presentation. There's going to be differences in signs and symptoms compared when we're comparing an intracerebral stroke to a hemorrhagic stroke. For example, intracerebral stroke will have more focal deficits and is more likely to lead to unconsciousness quicker than our hemorrhagic stroke. However, when we're looking at both of these strokes, we know that they're the result of hemorrhage within the brain. And that hemorrhage within the brain is going to increase pressure, either within the brain in terms of the intracerebral stroke, or it's going to increase pressure on the outside of the brain in terms of our subarachnoid stroke. Either way, what's happening is we're having increase of blood flow into a space within the brain where it's not normally flowing. It's going to increase pressure, increase intracranial pressure, and it's going to have a number of consequences for people in terms of signs and symptoms and deterioration. So when we're looking at intracerebral pressure, really we're looking at an equation between three things. We're looking at our cerebral perfusion pressure, or CPP. We're looking at our mean arterial pressure, which is our MAP, and we're looking at our ICP, which is our intracerebral pressure. So again, our CPP is our cerebral perfusion pressure, or the amount of blood that we're getting to the brain in order to allow for oxygenation and perfusion. So cerebral perfusion. We have our MAP, which is our mean arterial perfusion, which is really just our arterial blood pressure, or the amount of pressure we have in our arterial system. So this is our mean arterial. And then ICP is our intracerebral pressure, or the amount of pressure that we basically have on our brain. So you can see that this is written in equation form. So in terms of homeostasis, our cerebral perfusion of pressure, or the amount of blood that we're getting to the brain in order to allow for oxygenation, equals our mean arterial pressure minus our intracerebral pressure. So if we think about what that means, is we have a certain pressure in terms of the arterial system, which we minus by our intracerebral pressure, and that gives us the amount of blood that's actually able to penetrate the neuronal tissues and allow for oxygenation. So in terms of subarachnoid or intracerebral hemorrhage, what we said is we have a buildup of pressure within the brain, or we have blood leaking into a space which is not normally present and causing pressure onto the brain. So in order to increase ICP in these cases, we have that buildup of blood within the brain tissue. So if we start breaking these down into normal numbers, we'll say our CPP is normally 60. We'll say our MAP is normally 100. And again, these are just arbitrary numbers. And our ICP is normally 40. So that makes sense. 100 minus 40 equals 60. So we'll call this normal. So that's a patient who's sitting at rest, has no issues. We're maintaining this homeostatic level of 60. We'll say that's what we want to be at. That's our kind of golden number for CPP. So what happens when someone has a bleed within their brain, they're going to have an increase in their ICP. So we know that an increase in ICP in these cases that we're looking at is likely due to hemorrhage. So what happens is, say we increase our ICP now to 60. We know that our MAP hasn't changed. So 100 minus 60, well, now we're down to 40 in terms of CPP. And that's not enough. We're not at that homeostatic level. We're going to reduce our cerebral perfusion pressure, and we're going to have a decreased ability to supply the brain with blood. If we look at that subarachnoid hemorrhage, where we said that the patient normally has an initial loss of consciousness followed by a lucid interval, this is the reason. It's because we have a drastic reduction in our ICP, or sorry, a drastic increase in our ICP, which is going to have extensive decrease in our CPP. So say when that patient initially bursts that Barry aneurysm, if our ICP goes up to say 90 and CPP drops to 10, that patient's going to go to unconscious, followed by some compensation, which hopefully will have them regain consciousness. So this is an increase in ICP. So in order to compensate, there's not much we can do in terms of intracranial pressure. This patient's bleeding within their brain. Unless we stop it or get rid of the blood, there's nothing we can do about it. So that leaves us our map on the other side of the equation that allows us to make a difference. So if I increase my map to 120, and I have that minus my increased ICP at 60, well, I'm back to this kind of golden number of 60. So I've compensated. So we can see that in order to maintain cerebral perfusion pressure, if I have an increase in intracranial pressure, I have to increase my map, or I have to increase my blood pressure. So that's going to allow me to maintain cerebral perfusion pressure at the levels that I want it to be at, or at normal levels. But if we think about it in terms of the brain, this is going to have a number of specific consequences. And generally, if we don't correct the problem, or this patient doesn't have surgery or something done that's going to correct the issue, then they're going to die, because it kind of causes a cycle of increasing ICP, increasing blood pressure, increasing ICP, increasing blood pressure. So if we look at that in kind of an illustrative form, what we're seeing is an increase in intracranial pressure. So if we take a look, we'll say that this is our carotids coming into our circle of Willis. So we'll just kind of draw a very crude circle of Willis. We'll say this is our circle of Willis right here. So circle of Willis, and then we have blood flow leading off of it. So in this patient, we're going to say that we have some sort of hemorrhage. We'll give this person a subarachnoid hemorrhage, or they're going to have some sort of destruction to their circle of Willis, likely due to a Berry or saccular aneurysm. And we're going to have a communication now. So we have a communication of blood between the cerebral arteries and the space within the brain. So what's going to happen is we're going to start to see an accumulation of blood here. So blood starts to accumulate, and that's going to cause an increase in our ICP. So as blood accumulates in the brain, I see an increase in ICP. And if you think about it, the skull is an enclosed vault. So if I'm putting, and it really only houses the brain, so if I'm putting something other than that in there, or I'm pushing fluid in there that normally isn't there, it's going to increase pressure in that space. So I have a vault that normally only encompasses the brain. Now I'm putting something extra in. I'm going to increase pressure in that area. So, like we said, what's going to happen, we have an increase in ICP, is we're going to increase MAP in order to compensate. So that's what we're seeing. We have a hemorrhage, so it's causing an increase in ICP. So we know in order to compensate, this patient is going to have to increase their MAP. So we want to see an increase in MAP as well. And what that's going to look like is basically an increase in cardiac output and vasoconstriction. When we think about what happens is I'm going to start supplying more blood, or I'm going to be pumping blood with more pressure into the heart. So BP rises, so we start to see an increase in our BP because of this because we're trying to increase our MAP. So we do things like increase our stroke volume. We vasoconstrict. And we increase that mean arterial blood pressure. So because we have more blood being pumped out, we have some vasoconstriction. We're increasing the pressure in which we are pumping blood into the brain. So we've increased our MAP, so we're increasing pressure in which we're pumping blood into the brain. So as a result, what we're going to do, if we have a higher pressure system coming into the brain, again, we know that blood flows from high to low pressure systems. So what's going to happen if this blood's coming through with higher pressure now? So say we initially only had 1 arrow of pressure here, and it's allowed blood to pump through. Now we've got, say, 2 arrows of pressure, or 3 arrows of pressure. Say I only have 1 or 2 arrows of pressure here. What's going to happen is now blood's going to continue to move through into this space. And I'm going to further increase ICP. And again, if I look at what's going to happen, if I increase ICP further, well, then I'm going to increase MAP again. I'm going to increase blood pressure. I'm going to increase the amount I vasoconstrict. I'm going to increase my stroke volume. And again, as I'm pumping blood into the brain, I'm going to pump it with higher pressure again. So now, instead of having 2 or 3 arrows of pressure, now I have 4 arrows of pressure, 5 arrows of pressure. And although I increased this to say 3 arrows of pressure last time, I can overcome it again. And now more blood can make its way in. And now I have 4 or 5 arrows of pressure in my intracranial space. So what you can see here is this is going to cause basically a cyclic increase in ICP. So as I continue to have an increase in ICP, I increase MAP, which is going to increase ICP again. So it becomes very cyclical in nature. So the only way to fix this is to correct the problem. Otherwise, I'm just going to have increasing ICP, which is going to lead to increasing MAP, which leads to further increase in ICP, and the patient's going to consistently get worse. So we think about what's happening to our brain as this is occurring, and if we picture our brain kind of within our cranial vault here, so we'll say this is our brain. What happens as we increase pressure surrounding it is we push it the only place we can. So the brain's going to be pushed downwards through that foramen magnum, because we know that's really the only open space within the brain. So this is our foramen magnum. Really the only exit. So as we continually to push the brain down, we start to force the brain through the foramen magnum. And the problem with forcing the brain through the foramen magnum is we start putting a lot of pressure on our brainstem. So our midbrain, pons, medulla. So what's happening is our brainstem is being pushed through this foramen magnum, or it's herniating through the foramen magnum. Well, it doesn't really fit. So the problem is that it starts to be compressed. So we start to see compression of the brainstem as it's forced through the opening of the foramen magnum, and we start to see signs and symptoms related to that. So when we're looking at the signs and symptoms related to this increase in intracranial pressure and the cyclic response of the MAP to increase in order to remain or in order to keep cerebral perfusion pressure around our homeostatic normal, we look at developing or the potential of developing what's called Cushing's reflux. Now, unfortunately, Cushing's reflux only occurs in about 30% of the population who actually have an increase in intracranial pressure. But if not all of the signs and symptoms are present, generally some of the signs and symptoms will be present to give you an idea of whether this patient has an increase in intracranial pressure or not. And if we're looking at that in terms of the clinical sense, where this becomes important is differentiating those people who you think may be ischemic versus hemorrhagic, or that unconscious patient who you're not sure what's wrong with them. Look into their vital signs may indicate an increase in intracranial pressure, which may lead you down the path of hemorrhagic stroke in terms of differential diagnosis. So when we're looking at Cushing's reflux, generally the signs and symptoms we see are hypertension, bradycardia, slow irregular respirations, and then alteration in level of consciousness. So I think we can see why this patient would have an increase in blood pressure. The patient would become hypertensive. Because of the increase in intracranial pressure, this is going to lead to us wanting, or the body wanting, to increase its MAP, or increase the mean arterial pressure. So by doing things like increasing stroke volume, in vasoconstricting, we're going to increase peripheral vascular resistance, and we're going to increase our blood pressure. And that's where we get that hypertension from. Remember that this is going to be a cyclic increase, or we're going to be constantly increasing this MAP. So these patients should be relatively hypertensive. So we're not so when you're looking at in terms of blood pressure, you may see an increasing blood pressure, and these patients may have quite elevated blood pressures in response to this attempt to increase MAP. So in terms of our Cushing's reflex, hypertension is one of the things we're looking for. And we know that that is the result of basically an attempt to increase our MAP by increasing cardiac output and increasing peripheral vascular resistance by vasoconstricting. So we're also going to see bradycardia. And again, if we start thinking about what happens when we have increasing blood pressure, we're going to have a response. We'll say that we have, or we'll say that this is a kind of our carotid bodies here. We have our aortic arch. We're going to have baroreceptors in these areas that are going to, so we'll label those as baroreceptors. So baroreceptors in those areas that are going to respond to increasing blood pressure. So as blood pressure continuously increases, we keep vasoconstricting, we keep increasing inotropy so that we're having increased stroke volume. We're going to have recognition of that by our baroreceptors, and that's going to lead to some vagus stimulation in order to slow down our heart rate. So we know that we're going to have a signal sent back to our SA node that's going to be inhibitory in nature, or we're going to want to have a decrease in our heart rate. So the bradycardia is in response to this hypertension. As the blood pressure is consistently increasing, the body recognizes it, and we need to decrease our heart rate, again, in order to maintain that homeostasis. So we see bradycardia in response to hypertension. So that's a baroreceptor response to increased hypertension. Finally, we're going to see slow, irregular respirations. And the reason for having slow, irregular respirations is we know that our respiratory centers live in the pons and the medulla. So as we have herniation of the brainstem through the foramen magnum, we have pressure increasing on the pons, on the medulla, and we start to have dysfunction of our respiratory centers. So that increased pressure causes some dysfunction within our brainstem, and that's going to lead to decreased functionality of those respiratory centers. So we get slow, irregular respirations due to herniation of the respiratory centers. If you think about the other things that are going to happen, we're more likely to see things like a blown pupil in this case as well, because we think about where our cranial nerve nucleus lives. It's in that area of the brainstem. So these patients are often going to present with things like blown pupil, nausea, and vomiting, because all of those centers live within the brainstem. The medulla houses the vomiting center. The medulla or the pons, holds our nucleus for our cranial nerve 3. So we're going to see things like blown pupils and nausea in these patients as well. And our reticular activating system also lives very close to our brain stem. So as the pressure increases and we're putting pressure on that area of the brain, the patient slowly becomes increasingly more unconscious. So those are the signs and symptoms we're going to see with an increase in ICP. So important things to remember are this equation. So CPP equals MAP minus ICP. So we know when we start to see an increase in ICP, we can recognize why we're getting hypertension associated with that. That's in order to try and maintain those homeostatic levels of cerebral perfusion pressure. The things that go along with that is this is going to cyclically kill this patient. So as ICP increases, we start to increase MAP. Well, that's going to allow for more blood and more pressure to push fluid into the brain. It's going to further increase ICP, and this is going to cyclically lead eventually to death if it's not corrected. The signs and symptoms related to that are, again, usually called Cushing's reflex, and we're going to see things like the hypertension from the increasing MAP. We're going to see bradycardia because of a baroreceptor reflex when we recognize this increasing blood pressure. We see slow, irregular respirations because this patient is going to have compression and damage to the pontine centers within the brain, which are responsible for things like rate and depth of breathing. And then other associated symptoms are things like nausea, blown pupils, that are again related to compression of that area of the brain. These patients are at high risk of death, and this is one of the reasons why when we're looking at trauma patients, time on scene becomes extremely important. And even these patients, time on scene becomes extremely important because as they're hemorrhaging into their brain, there's nothing we can do to fix it. These patients need to get to an operating room in order to have pressure relieved and hopefully the area of rupture repaired.